having questions and answer to share. So I'd like to go ahead and get started. So first, I would like to thank you all for being here and for coming to the webinar. The webinar today is on building capacity to manage at-risk mothers and infants under 6 months, otherwise known as MAMI. To introduce myself, my name is Andy Kendall. I'm the TechRRT Program Director. As you'll see that this is a webinar that's a collaboration of efforts from many organizations. We, the TechRRT, it's our Technical Rapid Response Team, we are part of the Global Technical Assistance Mechanism for Nutrition. It's a new body that is coordinating technical assistance within nutrition and emergencies, and it's a place to be able to ask questions, technical questions on nutrition, get answers, get support, whether that's through quick questions to be answered, or whether that is deployment support or remote support to countries in need. The MAMI Advisor, so the Manage At-Risk Mothers and Infants Advisor, is being hosted by Save the Children. And that is a project that's been funded by USAID, by OFDA. So we're all collaborating together to make sure that we bring you this support, so to clarify what MAMI is, and so that you are aware of the support that is available. We will have 2 case studies today as well. I'll be explaining a little bit more, but we have Partners in Health and GO will be presenting these. With that, if we can go on to the next slide, please. Great, thank you. So today's webinar, first, introduce myself as well as others, as well as the objectives of the webinar. Hang on, there's something going funny with this screen, but it's back now. So first, we're going to go, after we do the introduction to the objectives, we'll get into what is MAMI, what's the MAMI approach, and the MAMI tool. That will be followed by building evidence for the MAMI approach. And then we will hear the 2 case studies, one from Ethiopia in GO. GO will be producing it from Ethiopia, as well as Partners in Health will be a case study coming from Rwanda. Finally, towards the end of the presentations, we'll have next steps in building evidence, and then we'll have a long session, hopefully, a questions and answer session. So I'm going to just briefly tell you a few kind of golden rules of our webinar and how we run them so that we know what to do. Right now, the people you see in the videos, these are all the people presenting today, and I'm going to introduce them all in just a second. But otherwise, if you can keep your video and your microphone off, that would be much appreciated, and it makes for a better webinar. Those buttons to do so are on the bottom left-hand side of the screen. If you're using a laptop, that bar can come up and down. So you have to hover down towards the bottom and it'll pop up, and you'll see where to go to mute and video, stop your mic, and stop your video on the left-hand side. If you don't do it, Ben, who's in the background managing the slides, will do it for you. So don't be surprised. I know a lot of people already have, but if you can introduce yourselves in the chat box now, that would be great. Introduce yourself, your name, your position, your organization, as well as the country you're coming from, that you're based in right now, that you're calling in from. I already saw before starting, we had some people from across the globe. We have from Yemen to Jordan to India, even Portugal. I'm sure also we have some from the States, amongst others. So looking forward to see how far and wide we can get an audience from today. Okay, so while you're getting acquainted with the chat box and introducing yourselves, during the presentations, whether that's the main presentations or the case studies, please go ahead and type your questions and comments in the chat box. And that way, during the questions and answer session, the person who is facilitating that will be able to pick out some common questions. We'll try to answer everyone's, but if we have an active group, then maybe we won't get to all, but don't worry, we will make sure that your questions are answered somehow. Finally, if I think I said it already, but if I haven't, this webinar is being recorded today. That is so that people who are not able to attend the webinar today are able to take advantage of the information that's being presented. We also will have the webinar in French tomorrow for anybody that you think might be interested. Finally, at the end of the webinar, we ask that you fill out an evaluation. It's very, very short. It's a SurveyMonkey. So the link will be put into the chat box. You can click on that link, and the evaluation takes less than 10 minutes, on average 6 minutes, and it does greatly improve the value of these webinars. So please do take the time to do that. And that should be being put into the chat box now, the link, and then we'll put it in again at the end. But if you want to open it now so that you don't forget, that would be great. Okay, next slide, please. Great. So the objectives of today's webinar, first is just to introduce the concept of the MAMI approach. Then it's going to present the MAMI tool for community-based management. And then we would like to share an overview of selected research and experiences in implementing the approach. And then finally, it's to inform on the MAMI technical support that is available now from Save the Children through the GTAM. TechRRT is there as I'm in our role for coordinating for technical expertise of the GTAM. As many people are already familiar with requesting through the GTAM, it will be the same approach, but I will explain that more later. On to the next slide, please. Okay, I would like everyone to present themselves that's going to be speaking today. I've already introduced myself. I'm Andy Kendall, and I'm the Program Director of the Technical Rapid Response Team. Everyone's going to go ahead and introduce yourselves in order, so I'm handing over now to Alice.
Hi everyone, so thanks for joining the webinar today. My name is Alice Burrell and I'm the Emergency Nutrition Advisor focused on MAMI with Save the Children, but supporting technically to the GTAM as well.
Great, over to you, Ritu.
Thank you, Andy. Hi everyone, I'm Ritu Rana. I'm the Nutrition Research Advisor with Goal Global and I'm based in India. Thanks.
Thank you. Hi everyone, I'm Matsie Nemerimana. I'm from Rwanda. I'm the Pediatric Development Clinic Manager working with Partners in Health in Rwanda.
Great, thank you. And I also wanted to introduce two more people. First, I'm going to let Sarah O'Flynn introduce herself as she is an important person in the MAMI world. So please, over to you, Sarah.
Hi everybody, my name is Sarah O'Flynn. I'm the Director for Emergency Nutrition at Save the Children. I'll be helping to facilitate the Q&A at the end of the presentation.
Great, thank you for that, Sarah. Apologies for not having Sarah's picture on the slide for everyone to see her. Finally, I also want to introduce Ben Allen. He is the Deputy Program Director for the Technical Rapid Response Team. He has been very instrumental in getting the webinar sorted out and launched along with Alice and everyone else. And he is behind the scenes today doing the slide management, etc. And I don't want to forget him because he's very important too. Wonderful. With that, we can go to the next slide. Okay, now all of the presenters who are not presenting are gonna turn off their videos, and I'm going to hand over to Alice, whose video should stay on, and Alice will do the first presentation. Thank you. Over to you, Alice.
Sure, so just to start with, what is MAMI? Ben, if you could go to the next slide. So MAMI stands for the Management of At-Risk Mothers and Infants under 6 months of age. Next slide, please. So what is the size of the problem amongst this age group? So on the slide, you can see some data which has been taken from an analysis done in late 2018 of DHS data from 54 countries over the last 10 years. And this totals 75,804 infants. So what you can see on the slide is this reflects a high burden of underweight, stunting and wasting in infants under 6 months of age. If I draw your attention to the wasted, we see that there's around 20% global acute malnutrition, around 10% of moderate acute malnutrition, and just under 10% of severe acute malnutrition in infants under 6 months from this analysis. So this is approximately 20% of the SAM caseload worldwide for children under 5. So just to say that there is ongoing discussion as to which anthropometric indicators are best to actually identify risk in this age group. There was a recent systematic review that found that weight for age was actually a better identifier of risk in this age group than the conventionally used weight for height Z-score for acute malnutrition in children under 5 years. So MAMI has also evolved past just focusing on acute malnutrition, and it encompasses risk of adverse outcomes for this age group. So this includes, for example, low birth weight, which is why that's also included on this slide in the bottom row. So here we can see that 17.8% globally are born at a low birth weight, so that's less than 2,500 grams. We see larger percentages of low birth weight in low and middle income countries, and particularly in Southern Asia and Sub-Saharan African countries. And so why do we include low birth weight? Well, that's because low birth weight newborns have a higher risk of morbidity, stunting in childhood, and long-term developmental and physical ill health, including adult onset chronic conditions such as cardiovascular disease. Next slide, please. So what's the challenge that we face? Well, for 6 to 59 months old children with acute malnutrition, we have well-known community-based treatment. But for the infants under 6 months, there isn't any community-based options. So unlike CMAM, which revolutionized care for uncomplicated cases over 6 months of age, under 6-month-olds are still primarily treated as inpatients. And the challenge here is that inpatient care poses potential health, social and economic consequences for the caregiver and the infant. And the treatment is still mainly focused on breastfeeding, mostly focused around supplementary suckling to re-establish exclusive breastfeeding. But what, for example, if there's non-nutritional underlying factors? So in 2013, outpatient treatment for infants under 6 months with a severe acute malnutrition was added to the WHO guidance. However, there was no guidance as to how to operationalize this. And so for the majority of countries still, infants under 6 months are being treated in inpatient care when they have severe acute malnutrition. So one of the other challenges is that when we look past, again, acute malnutrition and look at risk, newborns that are born at high risk, they have focused specialized care in sexual and reproductive health services. But unfortunately, this care often goes up to 1 month or a bit beyond. And once they're discharged from those services, they go into the general pediatric care. So there's then a gap here in terms of targeted continuation of care for these infants who remain at high risk. Next slide, please. So a possible solution is the MAMI approach, which we want to focus on in this webinar. So the MAMI vision is that every infant under 6 months of age at every community health service contact is nutritionally assessed and appropriately supported to survive and thrive. So the MAMI approach guides the holistic case management of at-risk infants under 6 months of age. The MAMI approach, as I said, doesn't just identify and manage nutritional risk, but identifies and manages overall risk of adverse outcomes in infants under 6 months. So as the approach is identifying overall risk, the intention is not to create a new separate programme for MAMI, but to leverage and build on what already exists within services for mums and infants. So on this slide, you can see that MAMI intends to sit across, for example, nutrition services like IYCF, CMAM, maternal nutrition, sit across health, so acute disease, chronic disease, disability, mental health services for mother or family members, social services, and other areas that may be needed to support the mother and the infant. So MAMI needs to work across all these different sectors and have active referral links for it to be effective. Next slide, please. So the MAMI approach links prevention and treatment. So taking a public health lens, on the slide you can see from the bottom. So primary care is prevention of disease. Secondary deals with early problems to prevent the decline to something more serious. And at a tertiary level, we want to reduce the impact of the disease. So on a nutrition front, MAMI dovetails with IYCF interventions that operate more at a primary level of intervention. Next slide, please. So within the MAMI approach, we don't distinguish between SAM and MAM. And indeed, we don't really refer to malnutrition, but at risk, as I mentioned before. And we look at growth failure. So acute malnutrition is a continuum condition. And for this age group, the treatment is the same. So even though anthropometric indicators have great advantages in identifying at-risk infants, anthropometry in itself is not a diagnosis, and it doesn't just identify nutrition-related risks. So anthropometric indicators identify infants that are higher risk of death and poor outcomes, and that may require interventions that are not just about feeding. Other categories of risk, as we mentioned before, are low birth weight, but also infants that are both wasted and stunted, among other things. So the MAMI approach also importantly considers the infant-mother pair together to assess risk. The infant's well-being is intrinsically linked to that of the mothers, so they are assessed and they're managed together as a pair through the whole process. Okay, if you could just click them. Thank you. So we typically equate being small with being malnourished, but it's not as simple as that. So some infants might be small and growing well, whilst others are small and not growing well. So anthropometry will tell you nothing about the underlying causes that we need to address. So even though it's a good screening tool, there can be other diagnoses underlying an infant being small. So some might be nutrition, some might not. And contributing factors to poor growth might be problems, for example, with breastfeeding or underlying disease. Some infants may not be breastfed at all. So breastfeeding support in infants under 6 months is absolutely necessary, but it's not necessarily sufficient to manage risk. Next slide, please. So this just shows an example of enrolment criteria for one area that we implemented the MAMI approach. And if you could just click them. So what you'll see is that through these enrolment criteria, we look at the infant's nutritional status, the mother's nutritional status, we look at feeding practices, the mother's well-being, and other risk factors such as low birth weight, premature birth, or multiple births. And then mothers or infants that have complications are referred for inpatient care. So these might be things such as IMCI danger signs, severe and prolonged weight loss, or severe mental health problems. Okay, next slide, please. So I'm now just going to give a very brief overview of the MAMI tool. If you want to have a look in more detail, we'll provide the link for you to go and have a look. But the MAMI tool was basically designed to provide health workers with a format to assess, identify, classify, and manage at-risk mothers and infants under 6 months in the community. So the MAMI tool can be used at any contact point with a mother and infant to assess for risk. Okay, next slide. So the MAMI tool has 4 components. The CMAMI tool framework guides the health worker in the assessment of the mother and child. So firstly, we have triage to identify immediate risks. Then if the triage identifies no reason, we assess the anthropometrics of the infant and mother, we look at breastfeeding, and we look at depression, anxiety, or stress. So counselling and support actions guides through the management of identified concerns, support actions for breastfeeding, supplementary suckling technique, non-breastfed infants and other support actions. And the counselling cards accompany those support actions. Then lastly, there's programme management cards. So these can be used or they can be adapted to fit with existing programme cards. And they include enrolment cards and weekly visit management cards. So in practice, this package is not necessarily conducted all the way through. It's quite a lengthy package. But what it is used as is a tool for training purposes and as a reference guide for staff. And the tool can be adapted to each different agency. Okay, next slide, please. So just to quickly take a closer look at the weekly management cards, this gives an idea of what a weekly visit to the MAMI team would include. So if you could just click, please. So we look at anthropometrics and growth monitoring at each visit, a physical exam, and we look at monitoring of the feeding and how that's progressing and the mother's well-being. And then at each visit, the MAMI tool guides the health worker on what support is needed. This could include one-on-one targeted counselling for a specific challenge, group education, family support or social supports. Okay, next slide, please. So we'll now take a look at some of the research that's been conducted on the implementation of the MAMI approach. And just to say there's a large amount of research related to MAMI, and I just selected a few examples focusing on documented programme experiences for the purpose of this webinar. Next slide, please. So first to look at a study by Save the Children into the cost effectiveness of the MAMI approach. So this was done in Bangladesh in the pilot of MAMI Tool version 1. And what we looked at was the cost differences between the MAMI model and standard inpatient protocol. So costs were identified looking at inputs, health system costs, efficiency data, so the number of admissions per month, scale-up costs and costs to caregivers. So what they found is that the absolute cost per clinic of the MAMI intervention is higher from a healthcare provider perspective, so per clinic per month. But they found that the MAMI intervention was more cost efficient for infant treated, and it was less costly to caregivers. So overall, the societal costs, the healthcare provider and caregiver, were significantly lower in CMAMI compared to standard inpatient protocols, although they did find that both were judged to be cost-effective approaches. Next slide, please. So next from GOAL. So GOAL documented their experiences of CMAMI in the Gambela refugee camp. They conducted a qualitative study in the camps and found that the MAMI programme was highly valued. Staff reported the need for MAMI to be simplified. And they also reported on some innovations that they're trying for the CMAMI programme at the moment. So one of the things is they are trying the use of a 2 MUAC thresholds to identify nutritional risk in infants under 6 months of age. And as part of this, have designed a reversible MAMI MUAC tape to support easy identification. You could click please, Ben. So this is the MAMI MUAC tape. On one side of the tape, it's the conventional tape for 6 to 59 months of age, and also to identify mothers with nutritional risk using the standard international cutoffs. On the reverse, this is used to identify infants under 6 months of age with nutritional risk. So the thresholds were selected based on existing evidence, and those are as follows that are currently being tested: is less than 110 millimeters for infants aged from 0 to 6 weeks of age, and less than 115 millimeters for infants aged over 6 weeks up to 6 months of age. Next slide, please, Ben. So GOAL also presented their programme data from May 2019 to January 2020, and this has been collected through digital data gathering. So in the first graph, this is showing the enrolment profiles of 114 infants. So what we can see here is that the most common age of enrolment is 0 months, followed by the younger age groups. Okay, if you could click, please, Ben. The second graph shows the enrolment criteria again for these 114 infants. And we can see that the most common reason for enrolment is on the far right-hand side, is mother reporting feeding challenge. So that could be that there was low confidence, that she didn't think she had enough milk, or that there was a problem with the breast. And then this is followed by anthropometric measurements, whether it's weight for age or MUAC, which is what we're using in GOAL. Okay, if you can click. And then this third graph shows discharge of 83 of the mother infants. The cure rate was 50%, and this is affected by a high defaulter rate due to a lot of fluidity in the camp population as families cross to and from South Sudan, as well as between the camp and host communities where many have families. But among the 56 who remained in the camp until discharge, the cure rate was 71%. So 13% were also referred to CMAM at age 6 months. This was 10 infants, 6 were enrolled at 5 months, 1 at 4 months, and 3 at 3 months. Okay, next slide. So another article from Save the Children. This was about their experiences of implementing CMAMI in the Rohingya response and integrating it into the IOICFE programme. They report on their experiences from November 2017 to July 2018, when they established 7 CMAMI sites. They had a high enrolment amongst those that were screened. So they had 1,964 infant mother pairs were referred. Of these, 762 were enrolled and 78 were referred for inpatient care. So they identified also programme challenges through group discussions with programme staff, and this fed into the improvements in version 2 of the MAMI tool. Some of the challenges they had were recruitment of suitably qualified staff, assessment difficulties with things like low birth weight and maternal mental health problems, and limitations in adaptation to the context, for example, with discharge criteria, they were very difficult to meet. Okay, next slide, please. And so lastly, from Partners in Health, they documented their experiences from a paediatric development clinic in rural Rwanda. So PDCs provide comprehensive and specific medical nutritional follow-up for children. So they reviewed a cohort of 316 infants less than 6 months, and this indicated that there was ongoing poor nutritional status. So 25% were severely underweight, and 5% were severely malnourished. In August 2017, they decided to integrate the CMAMI tool into the PDC protocol to address issues with accurate nutritional and feeding assessments and to ensure comprehensive guidance on assessing and managing malnourished infants. So this then shifted the treatment of the uncomplicated acute malnutrition in infants to the PDC from referring them to the district hospital. They also created a complementary algorithm to guide nurses and social workers in growth, failure, and malnutrition assessment and management. Okay, next slide. So as I said earlier, there's a lot more publications, and you can find these on the ENN page for MAMI. But now I will hand over to Ritu from GOAL to give us the first case study.
Wonderful. Thank you so much for that, Alice. Ritu, can you put on your video? Wonderful. There you go. And over to you now. Thank you.
Thanks, Andy. Thanks, Alice, for covering the technical details. Welcome, everyone. I'm Ritu Rana. I work with GOAL Global as a nutrition research advisor. And I'm going to share a case study from MAMI program in Ethiopia, which is implemented by our wonderful and dedicated country team. Next slide, please. Okay, so this slide presents an overview of GOAL's MAMI programming. In 2014, GOAL played a significant role in including South Sudani refugees in 2 camps in Gambela region. Total, there are around 6 to 7 camps, of which 2 are managed by GOAL Ethiopia team. Now, most of these refugee population included mothers and infants, And it is in response to this high number of vulnerable mothers and infants, Goal started integrating the MAMI approach into its wider nutrition programming. And since 2016, we are implementing the program formally using the MAMI tool. So where are we implementing the MAMI? Currently, Goal has 4 nutrition sites, 2 each in Kule and Turkudi camps. And all nutrition sites provide the following services. So we have 1000 days IVCF space, we have stabilization centers, outpatient therapeutic program, targeted supplementary feeding program, and blanket supplementary feeding program. And as far as MAMI is concerned, MAMI is nested within the first 1000 days IVCF space, and the services are provided by trained female nurses. Next slide, please. Okay, so moving to program flow, in terms of screening, we are very fortunate to have multiple screening opportunities. We have UN-led quarterly screening, we have BSF monthly screening, we have screening by family and community outreach agents using these specially designed MAMI MUSC tapes. Thanks to Alice, she has already covered this in her technical presentation, so I'm not going to elaborate on this. Regarding management, our program management, which is guided by MAMI version 2 tool, has 4 components. So we have enrollment using the ABCD criteria, followed by weekly visits. So weekly visits includes 2 things. One is monitoring of weight gain of the infant, monitoring of IMNCI danger signs, monitoring of the feeding status and maternal well-being. And the support is provided accordingly. Further, depending on the outcome of the weekly visits, follow-up actions are agreed between the service provider and the beneficiary. That is, whether to continue the visits or to discharge. We do have post-discharge follow-up at 1, 2, 6, and 12 months in our program. And again, we are very lucky to have an integrated program. This allows us to collect longitudinal data, and we do have plans to analyze the data once we reach enough number. Another important feature of our programming is digital data gathering and real-time monitoring. So we are using a ComCare application for data collection, and this program data is directly linked to the Power BI dashboard, which is monitored by our MEAL team in the country office. Next slide, please. Can we have the next slide, please, Andy? Thanks. Now I'm going to introduce you to one of our mother-infant pair on the left corner and one of our MAMI nurse on the right corner. So 20 years old mother with her 4 months old lovely infant Nyagwa arrived at our first 1000 days IVCF space as self-referral. This pair was attended by our MAMI nurse, Elsa. During the registration process, the mother told, I was in South Sudan before, but war occurred and people were being killed. I ran here for my life. She was referring to the Gambela refugee camps. She's been here since 2014. She has 9 family members. Sadly, her husband died in South Sudan and she met the father of her child here. But she says he does not support her and the baby. So that is the background of our case. And since we are working in refugee context, most of our beneficiaries have similar background. Moving to enrollment, once registered, ELSA assesses the eligibility of this mother-infant pair, firstly using the infant risk status and thereafter using the ABCD criteria. As far as infant risk status is concerned, where ELSA checked for multiple or twin birth, low birth weight baby, prematurity, orphan status, as well as visible wasting or recent weight loss. The infant was found not having any underlying risk. However, the pair was found to be eligible for enrollment as per the anthropometry and breastfeeding criteria. The infant had both weight for 8Z score and MUAC below the at-risk cutoffs, and the mother reported feeding issues. The mother said she feels her milk is not enough for the baby. Next slide, please. Okay. So following enrollment, ELSA invited the mother-infant pair for weekly visits. These visits included, as you can see in the pictures, monitoring Nyagwa's weight gain, checking the IMNCI danger signs such as temperature, respiratory rate, dehydration, any episodes of illnesses, as well as monitoring the feeding status and well-being of the mother. Accordingly, breastfeeding counseling support was provided. And in this case, the support that was provided was counseling on attachment, positioning, effective suckling, frequency on breastfeed, and exclusive breastfeeding for 6 months. After each visit, follow-up actions were agreed between the mother and the MAMI nurse. And in this case, the mother-infant pair attended total 4 visits and were discharged on the 4th visit. Next slide, please. Okay, so the pair was discharged as cured with infant's anthropometry and mother's feeding status, both falling under the normal criteria. Total length of stay in the program was 28 days, so roughly around 1 month. The pair has recently completed their 1-month follow-up and are referred to targeted supplementary feeding program because the infant is now greater than 6 months. In terms of program outcomes, you can see on the line chart the steady increase in infants' weight and MUAC, right from enrollment to 1 month post-discharge. Now, ELSA is looking forward to track the mother-infant status in coming months, that is post-discharge 2 months, post-discharge 6 months, and post-discharge 12 months. So that was the summary of our work with beneficiaries from enrollment to post-discharge follow-up. Please note our prospective plans are to shift from discharge to de-escalated follow-up. So rather than discharging, once the pair reach a classification whereby they are no longer classified as at risk, they would just be followed up periodically, that is once per month until they reach 6 months. And this is just to ensure that there is no further deterioration and reinforcement of positive feeding practices. And lastly, I'm pleased to share, apart from usual programming, GOAL has integrated various research components into its MAMI programming. This is for evidence building and our own organizational learning. Currently, we have 3 research components. We have MAMI MUAC tapes, which Alice has already covered. We have global health media educational videos, and we have planned for longitudinal data analysis. Additionally, in partnership with Jimma University, London School of Hygiene and Tropical Medicine, and Emergency Nutrition Network, we are testing the MAMI care pathway using a cluster randomized controlled trial in Ethiopia. So that's our future plan. Next slide, please. Okay, well, this is all we had from GOAL. Thank you everyone for joining us. If you need further information, please do not hesitate to contact us. Thank you. Over to you, Andy.
Many thank you, Ritu. That was a very interesting case study and very wonderful to get to see, actually, to follow one case. It's unusual these days for us to be able to actually do that. So it was quite unique. Thank you for that. Now looking, we're going to go to our next case study. That one is by Partners in Health in Rwanda, and over to you, Matthew.
Thank you very much. My name is Matthew Nemerimana. I'm the Pediatric Development Clinic Program Manager working with Partners in Health in Rwanda. I'm going to present you a case of how we have integrated MAMI approach, and also to talk about briefly what is PDC. So next slide. Next slide, please. So Pediatric Development Clinic is one of the interventions that are provided by Partners in Health, and this is from the partnership with Partners in Health and the Rwanda Ministry of Health, focusing on improving the health and nutrition and development of high-risk infants. This came in 2014 after evaluating and assessing, seeing that many high-risk infants were dying and others were having some developmental and malnutrition rates comparing to other children. And this was developed to just as one of the novel intervention to try to help those children to survive and thrive and ensure that they reach their full developmental potential. majority of children that receive are children who are referred from neonatal units. Those are children born with lower birth weight or who are preterm, and also children with brain injuries, mainly neonatal encephalopathies following birth asphyxia. But also we do have other categories of children with other complications such as trisomy 21 or those who have severe acute malnutrition and they are still under 1 year. And also children with malformations such as hydrocephalus, cleft palate or cleft lip, and children who are having developmental delay or who have post-central nervous system infection. These are mainly cerebral malaria and meningitis. The clinics are integrated into the public health facilities, and they are primarily managed by trained general nurses and social workers, and who deliver the structured package of follow-up care using designed protocols. And also they do get support from doctors, and the children, all children are followed up until they reach their 5th year. And since we have started, over 12,000 children have been enrolled. So we are currently working in 2 districts, but we are partnering with USAID to expand the services to one of the Longfan Part district. Next slide. Next slide. So from the experience, as we have started implementing the program, so we found that there was many challenges, and one of the challenges were higher rates of malnutrition among infants under 6 months at 3 months and at 6 months. And as earlier Alice talked about, so we had like higher percentages of children presenting with severe underweight, present 25%, and also have 5% of children were presenting with severe acute malnutrition. But also we have other children who were having inadequate weight gain. And this prompted us to just look at what are the root causes. And one of the causes that we found were that there was no comprehensive breastfeeding assessment that was being done by the care providers. And also because of that, there was limitation in providing appropriate breastfeeding counseling to the mothers. And the care providers were also not having adequate identification of feeding problems, and were not providing appropriate intervention to that. That was was causing that many care providers were using infant formula as quick fix strategies. Next slide. And now we're looking at what can we do to just improve the nutrition care that was being provided to the children. And in 2017, we have introduced the MAMI Tool, and we did by updating our protocol and making sure that we adopt the MAMI Tool into the protocol that was being provided. And then we have adopted the MAMI Tool to the protocol in 2009 when the version 2 was put in place. We have taken the tools and then integrated to the forms that are being used by the care providers, and also translated the counseling cards into Kinyarwanda so that many people can use that as guide to provide appropriate counseling messages. And one of the things maybe different from that is that we removed one question on lower birth weight, as the question was mainly most of the population that we serve are mainly with those issues with lower birth weight and prematurity. And then we developed an algorithm that can serve and help the care providers to use it to make a decision. Click, please. And the algorithm is basically trying to help all care providers so that they do not miss or miss to their identify the problems area and to provide early intervention. This is basic, and one thing that we introduced nutrition assessment was not people were not taking care of, to just see how the trajectory of weight gain is being done. And then also we followed up with the other parts as for the man, and this one, those which are in low plate, they must be referred directly to the hospital. And then those who are in yellow, those are the ones that are referred to the MAMI within PDC. Next. Next, please. Now I'm going to present you one of the case among the clients that we receive. And this is a 30-year-old mother, is married and with 2 children, and the child that we are going to be presenting is the third child. So the mother was being followed by the program at the health facility, but had a complication during the pregnancy and had anemia that made the mother to be referred at the hospital, and was hospitalized at the hospital. By the end, the mother was delivered with premature labor and was delivered by C-section, cesarean section. He delivered a baby at 27 weeks of gestational age, a girl, and with birth weight of 910 grams. So the baby was hospitalized at the hospital in neonatal care unit for 2 months and was discharged after 2 months with 2 kilograms. And as I mentioned, all babies with lower birth weight or other parental complication, they are referred to PDC. Next slide, please. So arriving to PDC, the baby was meeting the criteria to be followed in PDC, but also was having a good weight gain with 2,550 grams. And the main issue were about breastfeeding. The baby was getting tired when breastfeeding, and the mother was feeling uncomfortable when positioning the baby, and was anxious and having many concerns on whether the baby will not survive. And the mother had difficulties in expressing the breast milk at home and was having poor attachment. Next. Next. As observation that we've done, so we provided a mother with counseling to support psychologically the mother, and also supported the mother by providing counseling messages or using the MAMI tool, but also using the global health media videos, and that was mainly attachment and positioning. So just to mention that these videos, there are some of the videos that we have tried to translate into our local language, Rwanda, so that we are so helpful just to use them to provide counseling to the mothers. But also we provided education on cup feeding with expressed milk, since the baby was tiring easily when breastfeeding, and the mother had to use the cup feeding on top of the breastfeeding. And also we put the mother on frequent visit, and the mother was coming on weekly visit. So, and this was done until the problem was resolved. Next. So as outcome, the chart eventually was changed from the weekly visit to the standard visit. These are the visits that when the child should come, that are done at 1 month or 2 months, and 4 months and 6 months. And then after 6 months, they are done after 3 months. And then at 1 year, the child come every 6 months. And the mother-child interaction was improved. The mother was not having those concerns and was trying to help the baby using play and other activities. The breastfeeding attachment was improved, and the mother was able to attach the baby very well, and the child has maintained good weight gain, and now is 20 months old and weighing 10 kilograms, and all anthropometric measures and Z-score are good, above 2 -2 Z-score. Now what we are currently doing is try to integrate the MEWAC to the program, because as now we're not using MEWAC, because MEWAC are taken from the community level for all children under 5 years, but now we are trying to integrate the MEWAC as one of the tools that we can use and then collect data on that. Other thing that we are doing, in our clinics, we do provide social support and individual counseling and group counseling to all kinds coming, but that's why we did not include all patients around depression and anxiety, and we were planning to integrate those patients, even though we are providing such individual counseling, and social workers were doing that so that we can improve and have data on that. Next. So thank you very much. So this is the end of our case study. Thank you.
Thank you so much for that, Matthew. Very informative, very technical. I think it shows how well focused efforts can turn out. Wonderful. Okay, as we're coming up to the next steps before getting to the Q&A, I'm going to hand back over briefly to Alice. Alice, can you take over for the next couple of slides, please?
Yeah, sure. So next steps in building evidence. Yeah, sorry, next slide, please, Ben. Thank you. So this slide's really just to show that the MAMI network is really growing across the globe. This is a map that we did for the MAMI Special Interest Group meeting in December at the end of last year. And it shows some of the programs and research projects that are ongoing related to MAMI across various different countries and organizations. But I'm sure this is really just a kind of small glimpse into what is happening. And so this is really just to encourage everyone listening into this webinar to share your experiences, your research, your programs related to MAMI, so that you can join this network and add yourselves onto this map. Next slide, please. So just to introduce myself really and the support that I'll be giving to the GTAM on MAMI. So I'm basically available to provide technical support to the collective. So not just within Save the Children at all, but to anyone that wants to request technical support. Just to talk a bit about what I've been doing so far. So I started in February and I've been reaching out basically to countries within Save the Children, but also a few other organisations that have previously expressed their interest to implement the MAMI approach and need some help with what that might look like. So I've been exploring possibilities for integrating MAMI into their existing programmes, thinking about what that might look like in terms of activities, staffing, and what kind of funding might be required. So obviously for now, in the times that we're in with COVID, this support has to be remote, but once travel restrictions are lifted, this support can also be available as in-country support to teams to work through how they might implement the MAMI approach. So this support could include, for example, helping a country team or an organisation to determine whether there's a need for MAMI and what's the feasibility of integrating the approach into their existing programmes. Support with how to contextualise the approach, so how does it fit best in their specific programmes or the context, and also support to orientate and engage relevant stakeholders within that context to really know what MAMI is and to get buy-in. So just a few of the things that I'm supporting that are also kind of for the global good are the MAMI Toolkit and Compass module. So this is a very operational tool which guides step-by-step implementation of the MAMI approach. We've collated tools and resources that have been developed by organisations that have already experience in implementing the MAMI programme. And it's really important to note that there isn't any one right way to implement the MAMI approach. So what we've tried to do is bring together everyone's experiences and put together a kind of very much a guide to people to go through that process of what might work for them and access to the tools and resources that different agencies have created. So this will be available definitely by June 2020, if not a bit earlier. Then the MAMI video. So this is something that we're working on as well. It's a short 3 to 5 minute video that's meant for technical partners to basically communicate what programming for MAMI looks like. And we've done this through kind of interviews with beneficiaries of existing MAMI programs and program staff across Save the Children and Goal. So this will be finalised by June 2020 as well. Okay, next slide and back to Andy.
Thank you very much, Alice. And just to continue on with what Alice was just explaining on about what she will be able to do, how she can support countries, just want to give a little bit more background on all of it. The support, who can request? As Alice has explained, anybody can request, any agency, organization on the ground, national or international, or other stakeholders, that includes donors or government, with a nutrition technical need can request support. It can be a nutrition cluster as a whole or a sector group, and national organizations are strongly encouraged to request. What I'm presenting right now is somewhat the same for all TechRRT deployments. It's similar for how Save the Children will be doing it and how we'll continue in the future as the GTAM is launched. For now, until that GTAM is launched, you can continue to contact the TechRRT for this request. You see the email address there. You'll have an initial call with the MAMI Advisor and with the TechRRT in our role as coordinating for the GTAM specialized technical expertise. And you will work through the development of a TOR with support from the MAMI Advisor and the TechRRT. We help you through it, so you don't have to worry. Just contact us and we can work it out. So the question, golden question, is how much does it cost? In general, thanks to OFDA USAID, the grant that Save the Children has for the MAMI Advisor, costs can be completely covered under their grant. Just have an understanding of what does support cost and where resources are available, it is requested that contributions can be made. This helps to ensure sustainability of the service availability, and also make sure that countries that don't have any funds can still access the support. In general, the MAMI support is in country, is expected to be around 3 weeks in country, and the range in costs is around 15,000 to 20,000 US dollars. Remote support for 2 weeks, as an example, can cost around 6,000 US dollars. But don't despair if you don't have money. Costs shouldn't be prohibitive to requesting support. Please do ask, and where it can be covered, it will be. Specific budgets are developed for each request, whether that's remote support or in-country support, to figure out exactly how much it will cost, and then and at that time discussions can be had on whether or not you're able to contribute to that in part or full, to be able to cover the costs involved. This is particularly important, particularly for countries where funds are not available, and therefore Save the Children would use the OFDA funds to cover the support. Okay, with that, I'd like to go on to the next slide. please. Okay, this brings us to the Q&A. And as we have a few very important experts on the line, I would, taking the liberty, without asking them, to introduce them very briefly, or asking them to introduce themselves before we start the Q&A. First, we've got Marie McGrath on the line from ENN, who is, I'll let Marie introduce herself if she doesn't mind. Briefly.
Well, thank you, Andy. So my name is Marie McGrath. I'm one of the technical directors at the Emergency Nutrition Network based in the UK. We've been involved in MAMI since about, for a long time, the last, I think, over 10 years or so. And we coordinate a special interest group on MAMI, co-led by the London School of Hygiene, Mark O'Crack at the London School of Hygiene and Tropical Medicine, and very much in close collaboration with a range of policymakers, programmers and researchers. In particular, Save the Children and Goal have been really instrumental, and it's great to see the MAMI approach reflected so nicely and clearly, reflecting the work and collective thinking of this group. I would just like to mention to all on a practical note that the MAMI tool is being updated at the moment under this group. It will be reconfigured as a MAMI care pathway, reflecting what it is. It isn't a standalone tool, and there will be resources and materials and infographics and figures to really improve its accessibility. We've got a MAMI specialist working on this with a steering group. It will be available in draft form around end of June, July, and will be tried out in a few locations, and we'll be looking at piloting it in a randomized controlled trial in Ethiopia later this year, which I'm sure Marco could elaborate on. So thank you very much.
Fantastic. Thank you for that, Marie. And very exciting news to see some new tools coming out. With that, I also did want to invite Marco to present himself as well. Marco, if you're willing, would you please go ahead and present yourself, please?
No, thank you very much, Andy, and thanks, Alice, and everybody for great presentations. So my name is Marco Carrick, and I'm an associate professor at the London School of Hygiene and Tropical Medicine, and have been working on this again with Marie and with many on this call. So great to see lots of old friends as well as lots of new colleagues involved since 2008 was when we first began. So very exciting to see lots of people on this call and see Save and others moving forward. So thank you very much.
Great, thank you so much for that, Marco. And one other person I would like to introduce, she was on our webinar just a few days ago, Hattie Barthorpe from Goal. Hattie, would you like to say a couple of words, please?
Thanks, Andy. Hi, I'm Hattie Barthorpe. I'm Global Nutrition Advisor for Goal, and I'm currently working with Ritu on the MAMI program in Ethiopia, which has been operational since 2014, but first started using the MAMI version 1 tool in early 2016. And then we started using the version 2 tool when that came out in 2018. Thank you.
Wonderful. Thank you so much for that, Hattie. So I'm going to be handing over to Sarah O'Flynn to manage and facilitate the questions and answer session. And I'm also going to ask that everyone, all of the presenters, put back on their videos but as we go into it. But I'm also going to ask Marco, Marie, and Hattie if you would be interested in answering any of the questions or contributing at all. Please do feel free, and please also feel free to put on your videos if you're not shy. Over to you, Sarah. Thank you.
Hi, thanks for that, Andy. We've had some very active dialogue in the chat box, and thanks to Marie and Hattie and everybody for the back and forth, already answering some of those questions. If any of those discussions, if the people who asked questions felt like they still had more follow-up that they wanted to do, please do put it into the chat box, and I'll monitor that during the Q&A session. As I start the Q&A, I've been collecting all the different questions and trying to group them. And I just did want to say that there have been a number of questions around one of the most important and exciting parts about MAMI, and that is the integration of MAMI with so many different service points in which mothers and infants interact with the health system, but also outside the health system. And I know that there are a lot of MAMI implementers on the call as well who approach MAMI from different ways. So some of the areas have included the integration of early childhood development, maternal nutrition and maternal care pre-birth, in the ANC period, also CMAM, questions around MHPSS. So as these questions come up, I hope that some of our partners who are integrating MAMI into different service points would also put some thoughts into the chat box as well, or contribute to some of the answers. MAMI is certainly has a community of people who are sharing lessons, and so you're very welcome to bring your voice to the discussion. With that in mind, perhaps we can ask the presenters in particular about some of these entry points that were mentioned. So one was around the integration of developmental milestones, assessments, or counseling on physical stimulation, around home activities to promote early learning and motor development, whether any of the partners have had experience integrating those activities into MAMI. Another has been about integrating the approach with KMC for premature or low birth weight infants, and into growth monitoring and promotion. So those were the three particular areas that were mentioned, and I'll just hand it over to the speakers to see if there are any good examples of those integration points. Matthew, I will say that Katie has also responded a little bit about the ECD question in terms of the Partners in Health programming in Rwanda. So I don't know if you want to discuss that any further.
Yeah, I could talk about a question on the integrating developmental milestone for monitoring, and also the MAMI tools and ECD part. Our experience in the pediatric development clinic, we do focus on ECD, nutrition, and medical checkup. So they are well integrated together. And the way that we do is we try to use the tool by checking on the nutritional and the feeding of assessment of infants and children, but also we do have other tools that we are using to monitor the development milestone of children. So every time that children and mothers are coming to the clinics, there is focus on development monitoring. So we are using now a tool called GMCD. The GMCD is one of the tools that was developed, which is short, and there are many tools that are used in child development to check on milestones, but that was the tool that we have found that is more feasible, and it can be used by anyone who is trained, and it doesn't use a lot of time. And it is called Guide for Monitoring Child Development. That's the tool that we are currently using, and they're being used by the care providers, but we have other experiences from other countries where the tool have been used by community health workers and other trained professionals, and that has been so good and supportive. So that's what can just try to share with what we are doing, and I can also ask Kate to share more on that, because we have also ECD program.
Great, thanks for that, Matthew. Maybe Katie, if you want to put anything additional into the chat box or any reference websites for PIH's program, that would be great. I also did want to re-emphasize one of the slides that Alice presented at the beginning, that the goal of MAMI is really to have infants and mothers assessed at every entry point. And so the integration of this activity into any services that impact mothers and infants is really the goal, so that all of the needs are addressed and can help to mitigate some of the risk factors that mother-infant dyad are facing. We had a great discussion in the chat box around the integration of MAMI into CMAM, and how successful some partners have found that. But there was a question about if it's possible to integrate MAMI where there is no CMAM program, and I just wanted to throw that out to the partners. If you have examples or know of examples where MAMI has been integrated where there wasn't a CMAM program, potentially where there was an IYCFE program as an example, or an IYCF program.
Can I respond, Sarah? It's Hattie.
Yes, please, sorry. Having fun with the mute button.
Yes, so I just saw that pop up in the chat box. Thank you for that question. So Goal's experience was initially, when it came out, we were thinking, I think purely because we were nutritionists, that this should naturally be an adjunct to CMAM. That's where our sort of headspace was. But actually what we realized was that because one of the fundamental differences between MAMI and CMAM is that it's trying to identify at-risk cases. So those prior to actually becoming acutely malnourished or acutely undernourished, and also those who have deteriorated to such an extent where they need specific counselling and support to improve their nutritional status. So whereas CMAM focuses exclusively or through a clinical setting on the treatment of acute malnutrition, this is trying to incorporate the prevention and the treatment. So actually, we consciously decided to try and move it away from being seen and understood as an integrated component of CMAM. Because of one of these fundamental differences, because otherwise nutritionists just think of it as an adjunct and therefore it's just going to be a treatment, a curative care service. So the example that we have in Ethiopia now is that the MAMI service is integrated into what the team there called the 1,000 Days of Life Room, which is the IYCF counselling that's provided for PLWs, so from conception all the way through to the age of 2 years. So that's how it's integrated in the Gambella context in Ethiopia.
Okay, maybe if I could chip in on that as well, because I think it's a really good question, and I think there has to be flexibility for different people to adapt and integrate according to situation. But I think the other big difference is there are a lot more things, a lot more conditions underlying an infant being small. So it's not just a matter of inadequate intake. And I think so naturally it has to link a lot more with health, social, and other services. And so I think that's why conceptually is important. It links a lot more with the health sector. As well as the nutrition sector. But again, I think we need to perhaps reflect on some of the things that, with the benefit of hindsight, what might have been done differently with CMAM. And CMAM, huge success, but is hitting some barriers now in terms of integrating with child health services. And so that's why we're kind of reflecting on that. I think actually if we'd integrate from the beginning a lot more with health and with those wider services, that will also, we hope, prevent some of those barriers occurring later on down the line. So it definitely has to be a wider integration, so not just within CMAM, but within wider child health services, child immunization, growth monitoring, again, is a big issue because it's one thing to monitor, but this actually gives an action that can be done if an infant is identified as being small or otherwise vulnerable.
Thank you, Marco. I did just want to recognize that there are a lot of questions in the chat box about anthropometrics and anthropometric criteria for admission. Those have been answered, so I do welcome you to look back at the chat as part of the record for this, but I did want to open it up to the speakers as well. If there's anything that you want to say about the role of MUAC or weight for height or weight for age in terms of identifying risk factors for infants, as there seems to be a lot of curiosity about this. And also opening that up to Marco and Marie, Hattie, and any of our global experts as well.
Yeah, maybe I'll just start and then others can chip in. But I was just saying on the chat box there that if you look at the current version of the tool, so CMAMI version 2, is that MUAC actually isn't one of the enrollment criteria, but it's something that GOAL are using at the moment in Gambella and testing that out. And there has been recent evidence to show that MUAC and weight for age are better identifiers of risk in the under 6 months age group. but those, I guess, are kind of not validated thresholds internationally yet. So I think the recommendation is still to do weight for height, but within each organization, depending, I guess, on the flexibility you have, you can test out the new criteria, which evidence is starting to show are actually better at identifying risk. I don't know if Marco wants to add to that, because I think that's kind of from one of your recent research papers.
Okay, because I remember that the reason why we have weight for height at the moment is just because that was directly transferred from the older child guidelines. So weight for age is not at all controversial because it's widely used in growth monitoring, and there are clear criteria and clear, lots of countries already have the guidelines already enshrined for weight for age. MUAC is slightly newer for this age group, but there is lots of evidence. So Jay Barkley, Martha Montgomery, and others in Kenya, the Gambia, other settings have done some work showing that actually MUAC in Burkina Faso as well identifies high-risk infants much better than does weight for length. So the bottom line is weight for length doesn't work for a number of reasons. And one, it's very rarely done. Secondly, when it's done, the quality, even in a research setting, is not great compared to the other ones, because you get lots of variation around the length. And even when it's done, it actually doesn't identify the high-risk ones nearly as well as do weight for age and MUAC. So weight for age, I think that's pretty easy to bring into programs. There's no real controversy that I've heard about that. It's just a matter of when and getting it more explicitly into the nutrition guidelines versus the growth monitoring guidelines and other guidelines where it's already there. But MUAC is very promising, very easy. I think one thing that enables is the mother-led MUAC and lots more community involvement. So that's on its way. And one of our students, Christoph Hon, did a very nice review, systematic review on that last year, which we're looking to publish soon. And if anybody's interested, I'll be very happy to share. But yeah, basically it's a move away from weight for length towards weight for age, definitely. And that can be done very quickly. And MUAC is very closely on the horizon. So if anybody can collect data, that would be very valuable for the future. Thank you. Over.
Thanks, Marco and Alice. And just to point out that Ritu also added to the chat box a recent research paper, and that also has additional information on some of the anthropometric criteria. There was
I had one point, sorry.
Yes, go ahead.
It was just to flag the added benefit of MUAC, given that there aren't any cutoffs at the moment, but we know from the older age group in terms of CMAM coverage that we have very, very poor, despite the fact CMAM has been well integrated and there's been great exception from governments around the world to integrate it as an integrated service, part of the primary healthcare package of services. Our coverage is still very, very low. And so family MUAC provides us an opportunity to significantly increase therapeutic coverage for services. And so this is another opportunity for infants. If MUAC is used and accepted as one of the screening indicators, a proxy, a benchmark, proxy indicator for risk to refer cases for further assessment, we have the potential to significantly increase therapeutic coverage. So this is again another element that GOAL are trialing in Gambella at the moment, is with these MUAC, those MAMI MUAC tapes that Alice included in her presentation, is that the team are actually in the process at the moment of training, cascading the training down to mothers so that there can be home-based self-identification and referral to services. Thank you.
Thank you, Hattie. And that's a really good segue for a question that was posed around community engagement as part of MAMI. So I'll just pose this out to the various presenters. The question was how community members can be engaged in the MAMI process. The person who was asking stated that she imagined that there were different community nutrition support groups that could help to detect and follow up, and so was interested in any programming examples about ways that you've engaged the community themselves in the MAMI treatment program, or the MAMI program rather, including prevention.
So maybe just to talk, so I was previously with Goal, just to make it clear what I'm talking about, the experiences of Goal, but maybe Ritu or Hattie wants to take over. But with the programs there, we very much linked up with, for example, the mother-to-mother support groups, and we were doing training with the community outreach agents and officers. So as well as kind of family-led MUAC, we're also training them so that they can include that in their regular screening for the CMAM program and start including the under 6 months in that as well. So there's very close links to the community groups, whether they were existing already or establishing new groups in Gambella. And in, I think, the Rohingya response as well with Save the Children, we had kind of multi-sector community volunteers, and they would be the ones that would identify infants under 6 months who hadn't yet been assessed through the MAMI program and be referring them in to the clinic. So I think that's, yeah, obviously a kind of really key component to the MAMI program to ensure that you're identifying infants early. And I think especially in many cultures where at least until kind of 1 month of age, infants will stay indoors and you won't really see them presenting necessarily to health clinics or other community programs. So you kind of have to tie in with those systems to actually you know, find them and identify them.
Thank you, Alice. I'll also just give a shout out to the importance of community structures to support mothers who are enrolled in the MAMI program. And there's been a lot of chat around maternal mental health and psychosocial support and how we integrate that with MAMI. That's included in the care pathway, but certainly one of the challenges that programmers have found of how to train staff and also what level of MHPSS to expect of various MAMI staff engaged in the program. So it's an area we continue to learn how to do in the best way, but the idea is also to ensure that, or to try to link up with as many community structures that can support a mom, particularly those who are identified with particular risk factors around maternal mental health. I did just want to also ask the question, somebody was asking about examples of MAMI in non-humanitarian settings. I think that we actually have, at the moment we have 2 humanitarian settings as part of the case study that I've been mentioned, Cox's Bazar and Gambella. The Rwanda example isn't a humanitarian setting, I wouldn't say, but rather integrated with the Ministry of Health, but did want to just put it out to the presenters to speak to MAMI's flexibility across the humanitarian development spectrum.
Thank you for that. For our case, so we are not working in a refugee camp. We are just working in the community setting, just in a rural setting. And what I can just share as experience is that the tool is integrated to approaches being used there at the community health centers and the hospital settings. And also we are expanding the services to the community ECD approach, but also have a community early intervention program for children with disabilities. So we are all trying to use the tool to reach all those children that are having different issues. So I can just say that it works, and it's not being only used in the camp. And I can just say integrating it in our setting has been successful. And we are using task shifting approach, and mainly using social workers, and we are in a setting where there's no many nutritionists who are in the public setting, and also we use social workers and we train nurses, and also we have some experience of training some expert parents on the case of using global media health videos. That we use expert parents. Those are parents who have children who are preterm or who are above weight, and then they are trained on how they can provide some psychosocial support, but also trained how to use the videos towards other matters. Thank you.
Thank you for that, Matthew. With that, I'll just wrap up the Q&A. And given that we have so many participants on the call, I would also just make a shout out that Alice is still maintaining, along with another team member, the mapping of the MAMI programming globally. There have been a lot of examples discussed today on the call, so I would just ask, there's a website or an email address at the end of the presentation that will be provided, but if you could email mami@savechildren.org, we can add your programming into that map that Alice presented at the end of the presentation. I'll hand over to Andy to close.
Wonderful. Thank you all for the questions. Thank you for Sarah for facilitating so nicely, and all the presenters and guests who have been able to answer some of those